Good afternoon or good evening, everyone. This is Professor Satoshi Kuroda from Toyama University, Japan. Welcome to this memorial first web seminar conducted by Japan Neurosurgical Society and WFNS Education and Training Committee. We are very, very pleased and proud to welcome you to this web seminar tonight or today. Now, this time we invited Professor Zileli from Turkey, and we chose spine as the topics of this first web seminar today. Today, Professor Zileli and Professor Fujimura will chair this web seminar, and we have three speakers from Japan and Turkey. All of three speakers are very famous and expert spinal surgeon. So please enjoy today's web seminar. And I would like to let you know that this web seminar will be recorded and uploaded to the website of Japan Neurosurgical Society and WFNS Education and Training Committee very, very soon. So please enjoy talks by three excellent speakers. So please start today's web seminar, Professor Zileli.
Thanks a lot, Professor Kuroda. It is my distinct pleasure to be moderating this nice webinar series, the first one, with my good friend, Dr. Miki Fujimura, who is the co-chair of the WFNS Education and Training Committee. The first speaker will be Dr. Toshiki Endo. He's the professor, associate professor in Tohoku Medical and Pharmaceutical University. And he has many awards, especially the one in 2022, the Korean Society of Neurological Surgeons Lamy Award. Dr. Toshiki Endo will talk about the surgical management of intradural tumors and vascular lesions. Please, Professor Endo.
Thank you very much, Professor Kuroda, Professor Zileli, and Professor Fujimura for the kind introduction. My name is Toshiki Endo from Tohoku Medical Pharmaceutical University, Sendai, Japan. It's very honored to have a chance to talk about the surgical management for the spinal lesions. Thank you very much. Is my slides look okay? So today I would like to discuss in a short time about the how we treat the spinal cord lesions, especially vascular lesions, including the cavernous malformations and the hemangioblastoma. And also I would like to show a case of the craniocervical junction AVF. So in the latter part, I would like to introduce a multi-center study of Neurospinal Society Japan, which is recently published papers about the intermedullary tumors and also the spinal AVMs. So consensus in neurosurgery as a whole, and especially I would think treating the spinal cord lesions is try to have a balance of a cure, which means if we try to take the tumors, complete resections. If it is a vascular lesions, we aim for the complete obliterations. But we try to achieve functional preservations. Then this is a spinal cord at the same size images of the brain and spinal cord. As we all know, the spinal cord is very small, as like your little finger size. Then this is all the important nerves and spinal cord tracts running along the spinal cord. So it's very, I would say a very complex surgery at a time. So, but we have to be very brave to tackle on difficult lesions. And I would say surgical treatment should play an important role to achieve these goals. So in our facility, we have pretty much many adjuncts for the surgical assistance, meaning we try to do all the cases of intraoperative neuromonitoring, especially for the spinal cord lesions, motor evoked potentials, and sensory evoked potentials. So we aim to minimize risks of the neurological injuries. Then also, we sometimes utilize this endoscope, which is actually, we can use the indocyanine green video angiography from the endoscope. So this is actually the case of the anterior spinal artery aneurysm ruptured, then the SAH occurred. So I just want to show the images of the indocyanine green and ventral spinal cord. We can approach to these lesions from the back, posterior, and we still can manage the anterior lesion ventral to the spinal cord without manipulating the spinal cord. So which should be the safe, operation, I would believe. Then here in the last part, we can see the preservation of the anterior spinal artery beautifully after clipping of the aneurysms. So the patient was secured, complete of the obliterations of the lesions, as well as the functional preservations. So if we have to encounter the intramedullary tumors, we have to go inside into the spinal cord. So from the textbook, we all know that there is a safe entry approach tracts to the intramedullary spinal cord, meaning if we have a lesion which has lateral side, we can mainly use the dorsal root entry zone. Then also, if we have a lesion in the middle, we can use the posterior median sulcus approach, trying to follow the venous structures. So here, I would like to show a case. This is actually the cavernous angioma, a 37-year-old man. He's complaining of chest pain and left leg paresthesia. I assumed that he had one hemorrhage, but we discussed about the surgical indications. Then we decided to take this lesion out from the dorsal root entry zone. This is thoracic lesion. So this is a surgical video. I hope the image is working very well for you. So this is the left side is the cranial, and the right side of the videos is in the leg. So I already have started dissecting the lesions, and this is a really short video, so I already took it out. So try to keep you focused a little bit more. So I just rewrote images here. So this is the dorsal root entry zone approach. We follow the vessels. Sometimes I use the needles. Try to see the margin between the lesion and the spinal cord. So as I mentioned, I use the MEP and SP monitoring. Then thankfully, he didn't have any deficits after the surgery. He was a nurse in the other hospital, and he returned to work 2 weeks after the surgery, which was very thankful to those monitorings and the surgical techniques of the microsurgery. So this is another case of the hemangioblastoma. This is a 20-year-old female, right side pain and weakness. So there is an enhanced lesion in the thoracic T10, which is relatively large tumors. So it's really embedded in the spinal cord. So T2 high lesion is extending from the even cervical to the thoracic. Then we did the angiogram. This is the image, but we have hypervascular lesions with the feeders and the drainers. So on the left up corner, you can see the fusion images with the CT and MRI and the digital substrate angiograms. So we can see the tumor locations as well as the feeders and the drainers. So actually it is important to have these images strategy, how to tackle the hemangioblastomas. It should be the same in the brain lesions. Then as you can see the ICG, there's feeders first and the drainers in the latter. So we try to secure the margin between the tumors and the spinal cord. Then we try to be sharp as much as we can, then try to take it out the lesions from the spinal cord. As you can see, the gold clip, which is the temporary clip, which I put it on in the feeders, so we can manage the vascular lesions. Then in the last, you can see in the left, there's drainers. So we preserve the drainers as long as much as we can until the end of the tumor removals. So the strategy was successful and the patients didn't have any neurological deficit after the surgery. MVP and SCP work fine for us. So the last illustrative case is the cervical junction, cranial-cervical junction AVF. We may encounter these cases by the subarachnoid hemorrhage. Of course, we neurosurgeons see many subarachnoid hemorrhage patients. Then we do the intracranial, for example, MRA, CT angio, and try to find the cerebral aneurysms intracranial. But in this case, he didn't have those aneurysms. And there's also the intramedullary hemorrhage. So he actually suffered cranial nerve palsies and a hemiparesis. So this is a lesion. You can see the white spot here, and intramedullary hemorrhage and ventral to the spinal cord. So this is the angiogram. So you can see the vertebral artery angiogram. Then the lesion is a very bad location, but very tiny fistulous lesion, which you can see in the red circle. Then this is actually the fusion image with the MRI and the digital substrate angiography made from the rotation angiography. So you can clearly see the lesion is on the ventral spinal cord, lateral. Then the lateral spinal artery is a feeder. Then we were not actually sure how these how these lesions is fed by the anterospinal arteries. So from these locations, and we decided to do the direct surgery for this case. So the question is how we can approach these cases. We do the lateral approach, lateral posterior approach. We do the C1, C2 hemilaminectomy, and the patient was positioned prone. And you see the right side. This is the from the posterior lateral view of the spinal cord. You can barely see the center of the lesions and the fistula. You can just see the drainers. So for these cases, I think utilization of the endoscope is useful. So this is a surgical video. Actually, this is a microscope combined with a ICG endoscope. So the images start from this is the left vertebral artery. The cranial size is on the bottom of the images. So this is actually the ICG endoscope image. You can see the green light coming. This is a feeder and the drainers. So this is the lesion. The important message here is we didn't see any contribution from the anterospinal artery. So anterospinal artery, I'm just gonna go back a little bit here. So here is the lesion and the anterospinal artery is this. So we didn't see any contribution from the anterospinal artery to the fistula. So what we did is we understand the vascular anatomy, then especially we have to preserve the vessels like here, these things. I hope you can see my arrows, but this is the normal vascular network, which is just circulating the spinal cord. So we have to take those abnormal fistulous connections from the spinal cord, peel off, but we have to preserve. So for that reasons, this ICG endoscope was very useful. So we go back to microsurgery, microscope. Then after we understand the vascular anatomy, we try to take it out, the lesions, by cutting, fistulous portion connections one by one, take it out, try to preserve the normal circulation of the spinal cord. So by achieving these manipulations, meticulous coagulation and cut, we finally completely obliterate the lesions. So we were able to insert angled endoscope again to make sure complete obliterations of the lesions. Then the patient didn't have any new deficit afterwards. He actually had a hemiparesis and lower cranial nerve palsies, but which eventually resolved, and the patient went back, returned to work. It took time, but he was able to recover very well. And this is the final angiogram. You can see the complete obliteration of the fistulas. And this is the left vertebral artery, and you can see the anterospinal artery, which didn't have any relation to the lesions, but which is, of course, preserved. So this is the clip that we used to obliterate the fistula feeders. So I just come to the latter part. Then here I would like to introduce the multi-center study, which Neurospinal Society, actually, Professor Hida, he is going to talk in the seminar later. He was a dean at the time when we did these intramedullary tumors and the cranial cervical junction AVF multi-center studies. So this is the multi-center registry of the 1,000 surgical treated intramedullary tumors in 58 centers, which as results was already published in 2022 in Neurospine. So please refer to the paper if you're interested in. And this is actually the 10-year registry of the Neurospinal Society neurosurgeons in Japan. And as you can see, ependymoma, 361 cases, was the most frequent. Then also hemangioblastoma and cavernous malformations, which I introduced illustrative cases, followed. Then we have various grades of astrocytoma. Then there is also the other cases, including subependymoma and metastasis. There's a lot of results, but for the time sake, I just focus on this part. This is the McCormick score, and you can grade the patients by how much they can walk. So the blue bar is a grade 1 normal gait. Then the orange bar is a grade 2 mild gait disturbance. So grade 1 and grade 2 are those who can walk independently. So if you see the bars, this is the pre-operations. 59% of the patient can walk independently. However, as we experience, even though we use the MEP and SEP neuromonitoring, the patient may suffer neurological deteriorations after the surgery. So at discharge, after the intramedullary tumor removal, the patient may suffer deteriorations. However, important thing is that 6 months and 12 months, patient may recover. It's very important multimodal treatment, including the rehabilitations, and also time helps us. So after that 24 months, you can see 72% of the patients can walk independently, which is more than preoperative. So intramedullary tumor removal, as we all know, that it's not easy case, but we have to be brave and tackle on and try to take it out as much as we can. Then we try to do the same thing, which is try to preserve the neurological functions. So we group from the Neurospinal Society of Japan. we have did a sub-analysis, including the 361 ependymoma, hemangioblastoma, cavernous malformations. So we have published the papers from each subtitles and sub-analysis for each subtypes tumors. So again, if you're interested in, and if you encounter these rare tumors, you can refer those papers. Then you can see how the Japanese neurosurgeons do and treat these cases. This is one example. This is actually the Dr. Takashima from the Nara Medical University presented. This is actually the hemangioblastoma which I presented. Then the comparison between the sporadic and the VHL case, von Hippel-Lindau cases. So Dr. Takashima did analysis. He compared sporadic cases and von Hippel-Lindau cases. This is actually the 170 cases from the 1,000 cases of the tumor registry, which we built it on. So this is the von Hippel-Lindau disease cases. The patient is younger, then the weakness, they have more weakness. So the patient's symptom was severe. Then the preoperative gait disturbance, the patient may suffer gait disturbance more, especially in von Hippel-Lindau cases. Then the important thing is here. So as we showed, we could achieve the complete of the resections of the tumors. But important, von Hippel-Lindau cases, if we didn't do the total removal, total resections, Kaplan-Meier curve was not so great, meaning von Hippel-Lindau group patients may suffer recurrence after not total resections. So in other words, total resection is important, especially in von Hippel-Lindau patients. Of course, it's important for all the patients, but as we see the data and registries, we can see clear message that we have to focus on to the complete total resections in such cases. So this is actually the one of the last slides that I would like to show. This is a very short introduction for you to how we did the multi-center study for the angular architecture craniosacral junctions, AV fissurals. Actually, the left side is this is the paper written by the Dr. Hiramatsu in Okayama University. This is actually the study from the Japanese Neurosurgical Endovascular team society. So this is 2018. Then he wrote a very good series of the cases, and he classified cases. Actually, this is very difficult to have a diagnosis of these cases, but he described that beautifully about the angular texture, classifications and the diagnosis help. So we can have a type 1 dural AV fistula, type 2 radicular AVF, and as you can see, we also have an epidural and a perimeter AV fistula. The case that I presented was actually the type 5 perimeter AV fistula. You can see this here, which we may encounter more on the ventral surface of the spinal cord. So this is another study that the Neurosurgical Spinal Society did it. Neurospinal Society did it, which is we actually was really curious about how we treat these cases, especially do we do the direct surgery versus endovascular surgeries. So I think it's important to discuss, and we know I only do the direct surgery, then I don't do the endovascular surgery. But I think endovascular treatment is taking a very important role in treating surgical vascular lesions. But we have registered 97 patients retrospectively and compared the surgical results. So you can see the 5 points at the right lower corner here. So we have 97 cases registered from 29 centers in Japan. So we have treated these cases from the 78 cases by the direct surgery. Then we have done the endovascular treatment in 19 cases. And actually, the important message here is the revision rate, meaning we have achieved a complete of the ovulations more in the first surgery by direct surgery. So revision rate is 2.76% by direct surgery, and 63% by endovascular treatment. And ischemic complication rate is more in the endovascular treatment. So I think, the surgical treatment people think that this could be the invasive treatment. We have to cut the skin, open the cranial and the cervical. But if we see the spinal cord by direct vision, then try to preserve the important vessels, but try to cut only abnormal vessels, which we can do it by the direct surgery. So which sometimes I believe, which is less invasive treatment. About the modified Rankin scale improvement cases, there's a minor significant difference, but we have a more direct surgery may have a good improvement rate and less complication rate. So actually, this is the last slide. And I have reviewed cases of the intramedullary tumors and also the vascular lesions. But I think we can share the goal, which is we try to achieve maximum resections if it is tumors and complete obliterations if it is epiphyseals or vascular lesions. And importance, functional preservation, which is very difficult. And we have to still try to improve, the monitoring, how to read the monitoring, and it's very important issues. But again, we have to achieve these two goals. So key message to the young neurosurgeons and including me is neurosurgeons to keep trying to improve treatment results by using many adjuncts and try to include all the methodologies, and multimodal treatment is important. So thank you very much for your kind attention. Then I would like to close my talk. Thank you very much.
Dear Dr. Endo, it was a great talk. I thank a lot for giving the results of the multidisciplinary study of Neurospine Society of Japan. There is one question from Dr. Marwan Chamil asking CTA or MRI or MRA or MRV is the best procedure investigation of choice. What is the best before surgery?
Thank you very much for the great question. Maybe I would assume that this could be the question for the vascular lesions.
Probably,
because
yes.
We have a very pretty much many modalities, including the CT angio and MRI. Then, as we all know, those CT is, MRI is evolving. So we can see many things which we were not able to see, let's say 10 years ago, 5 years ago. Then at least my sense is the gold standard is trying to see about the vascular lesions, spinal vascular lesions. Gold standard is the digital subtraction angiography, so DSA. We have MRI and MRA, and we use it. We try to see a vague image of the vascular lesions, but try to do the surgery. We have to see clear image. Then this is my private opinion. Maybe Professor Hida may have a different opinion, but I think the DSA is the most important and the gold standard.
But if you compare CTA or MRA, which one is better, do you think?
I think right now, if I need to choose one, I would choose the CT angiogram.
CT angiogram. Okay, thank you. The Dr. Miki Fujimura will comment on that question, I think.
Thank you. Thank you, Dr. Endo, for a great talk. Just one question from me. You showed a very beautiful IC green intraoperative angiography. So my question is it IA or IV angiography?
Thank you very much. It's also the very important part. And the image that I showed was IV injection. So to add some comments about the intra-arterial ICG and intravenous ICG. I think most cases, I think intravenous ICG is good enough.
Okay, thank you.
But like you mentioned, you might have already know, but IV injections, we have accumulation of the ICG, so we cannot repeat frequently. So especially the cases, a very difficult case, meaning I assume that before the surgery, okay, this is a very complex case, so we need to repeat the ICG often and often. So for those cases, I selectively use the intra-arterial ICG.
Okay, I agree with that. Thank you.
Okay. I think if you make a small summary of Dr. Toshiki Endo's talk, the intramedullary lesions, tumors, and also vascular malformations should be treated by current techniques using very delicate microdissection plus intraoperative monitoring plus a good planning of before surgery investigations like CT angiography, MR images, and others. And especially vascular malformations needs special techniques during surgery, ultrasonography, ICG, and probably sometimes you didn't mention this, but interventional things probably. Would you like to make any addition of these comments, Dr. Endo?
Yes, thank you. I would like to add one important message because one of my colleague of the endovascular treatment team would be mad at me. Which I mean is the endovascular treatment is very important for the vascular lesions. What I showed was direct inspections and the direct manipulation of the spinal cord vascular lesions is important for especially for the craniocervical junctions lesions. For as you do it, thoracic dural AV fistula and epidural AV fistula in the lumbar spine, these cases is very well treated by the endovascular treatment. So important message is we have to see the vasculature and we have to, let's say, we have to understand the vascular anatomy and we decide. We need to have both modalities. I just don't say that, surgery should be, but we have to decide if surgery should be, we have to provide the direct surgery to the patients. Then we still need to discuss. That's my message.
Thank you. Are there any questions? Dr. Fujimura? There is no questions. Okay. Thanks a lot for nice